Associate Professor Bente is an infectious diseases physician and clinical researcher at Peter MacCallum Cancer Centre and the National Centre for Infections in Cancer. His research interests in the area of infections in cancer patients encompass translational immune profiling for infection risk prediction, clinical studies of infection risks with new cancer therapies, and clinical trials of vaccination in haematology patients. And today, we are very lucky to have Ben speaking to us about infection prevention and strengthening immunity. So welcome, Ben. Thanks so much.
Thanks, Narelle, for the kind introduction, and certainly thanks to Myeloma Australia for the kind invitation to speak today. Before I start, I just wanted to declare these are my disclosures. And I think, I do apologize that some of the slides are more technical and very clinically focused, but I think, it's good to sort of put it into, I'll try my best to put it into context for everyone. So before we can talk about, preventing infections in, patients who have myeloma, it's often important to think about what are some of the patterns of infections that we do see in looking after myeloma patients. I think the first thing, as you can see from this slide, is to think about the different phases of myeloma treatment from when people first start on treatment, for those who are more transplant eligible, and then unfortunately later on when there's disease progression, that the patterns of infection, as you can see summarized in this slide, can be very different. So at the start, it tends to be perhaps more bacterial infections, whereas during stem cell transplant, there are different phases of recovery after stem cell transplant. In the early days, again, more likely to be bacterial type infections, but later on, viruses become more important, especially viruses that we have encountered before growing up, which can come back again as what we call viral reactivation, or picking up new viruses, as we all know from the recent pandemic, things like viral respiratory tract infections, like unfortunately COVID and influenza and other respiratory viruses, which perhaps are less commonly known, but unfortunately certainly affect to particular types of therapy. For example, proteasome inhibitors such as bortezomib. There's an association with what we call herpes zoster, which is the chickenpox virus reactivating. And so we then have to try to target that more to try to prevent that from happening during treatment. There are also some associations such as with what we call high-dose steroids and a particular type of infection called pneumocystis, which is an unusual type of fungal infection that can affect the lungs. So that's why often when a number of myeloma patients, when you're on corticosteroids or dexamethasone, that's when you notice that you're on a preventer as well during that time. So this is more just to summarize the different patterns of infection that we do see across the different phases of myeloma treatment, and also associated with certain types of treatment. These summary slides are just more to give everyone a bit of a flavor that, depending on the type of treatment, the rates of infection can certainly change. In general, when someone's starting out, the rates of infection generally range between 10 to 20%, whereas later on, when we use things like monoclonal antibody therapy, which is the MOABs, as you see in that slide there, and things like daratumumab, alatuzumab, and when it's more used for when the disease is more active, that's when we see perhaps a slightly higher rate of infection between sort of 20 to 30%. But these are things that we anticipate, can happen, and therefore then, as you can see from subsequent slides, we'll talk about how we can try to reduce the risk for these infections. So I'm just covering here in this other part of the slide, the newer generation therapies that some people might be on them as part of clinical trials. For example, bispecific antibody therapies and CAR T-cell are very new in the myeloma treatment space. And certainly these are early reports of the type of infection patterns and rates that we see with them. So in terms of what the risks are for infection, I always like to think about it as several factors. One, of course, At a patient level, it depends on how someone's performing and how active someone can be. And certainly the more active someone is, the lower the risk for infection. Then there are some risk for infection connected to the myeloma itself. So for example, unfortunately, having a higher burden of myeloma can mean a higher risk for infection. And certainly things, for example, that the myeloma itself can impact, such as low red blood cell count, low white blood cell count, can certainly impact then on risk for infection as well. Then, as I touched on before, there are some treatment-related factors. So it's the types of treatment, the use of steroids, and certainly how much treatment someone has had before can certainly impact on their risk for infection. So how do we try to prevent? That's all the bad side of things, but certainly let's think about how we can try to prevent these infections from happening in the first place. So I like to think about it in sort of several steps. I think one of the key steps is to, of course, control the myeloma, because when we know that there's less myeloma around, or if there's very little of it, then certainly the immune system can recover, and therefore then the risk for infection is lower. Now, that's something as an infectious diseases doctor I can't do much about, but of course that's where your clinical team, your myeloma clinical team certainly play a huge role in the first point. But what we do advise about is what we call prophylaxis. So what can we take on a day-to-day basis, or maybe a couple of times a week, to try to reduce the risk for those infections that I've highlighted before. So for example, we can't just use, this could be antibacterials or antibiotics or antivirals, and some types, slightly different ones called antifungals, which we don't use that often, but we can't just use it all the time in everyone. So therefore, it must be targeted to when someone's most at risk, for example, after a stem cell transplant, or targeted to certain types of treatment, as I'll go through later on. So what about things like, if someone's immunoglobulin, which is basically antibody levels in our bodies, if they are low, then whether, replacing that could help, reduce the risk of infection as well. And of course, vaccination is very important, because that helps to strengthen our immune response and our immune system to help ward off some of these infections that we'll cover. So again, these are slightly, further details of it, but certainly what we call antibacterials are quite, commonly used, and of course for treatment of infection. But how in these couple of slides, I'm just trying to highlight how, there's been some studies to look to see if we can take it regularly to prevent infection. So in this case, in the much older studies, there perhaps shows that when we use these types of antibiotics, so trimethoprim sulfamethoxazole is Resprin or Resprin Forte that people might come across or be well familiar with. And fluoroquinolones is a type of antibiotic called ciprofloxacin or levofloxacin. And in those early studies, taking it regularly to try to prevent infection, unfortunately, didn't really make much of a difference. But in a later study, the use of a type of antibiotic called levofloxacin showed that perhaps there was lower rates of fever and certain types of infection, but unfortunately, it made no difference to the overall outcome of the disease, when we follow patients up for much longer. But what was worrying to us is the use of, as I'm sure we can appreciate, when you use antibiotics for a very long time, then there's a risk of what we call resistance developing. So the bacteria in our bodies and our guts becoming then more resistant to the particular antibiotic that has been used more regularly. So there's always a trade-off that while, sometimes having antibiotics regularly can be helpful, other times there are always, unfortunately, a downside to it as well, in particular, what we call the emergence of more resistant bacteria. So again, not to go labor the same point, that was for when people first start their myeloma treatment course. And this slide is more to cover the point about during stem cell transplant. if we use antibiotics regularly to prevent infection, does it actually work? So again, much similar to what I've discussed before, the rates of fever perhaps could be lower, no difference in what we call mortality or outcomes from myeloma. But unfortunately, because we're using these antibiotics more regularly, then the emergence of resistance to those antibiotics. So at the moment, we are not recommending that people take these types of antibiotics routinely. Of course, these are considerations for your doctors to discuss with you what's appropriate. This is just general patterns. It doesn't mean that it's specific to everyone's situation. So what we're saying is that it's not routinely recommended for everyone to always have antibacterials for during the start of treatment or for stem cell transplant. It's very different to treatment of an infection. So once you have fever or once you have a proven infection, this is a very different scenario, of course. So we say that, of course, everyone's situation is different, and it can be considered if, unfortunately, someone tends to get lots and lots of infection, then perhaps this is a way to try to reduce the burden of that. So what about antiviruses? So there are, for example, certain key viruses like what we call herpes zoster. So there are various types of herpes viruses, but the two most common ones are herpes simplex, which is the cold sore virus, and herpes zoster, which is the chickenpox virus. And so once we get exposed to these viruses as we grow up and get older, unfortunately, they never disappear from us completely. They remain dormant in our cells. And then, when unfortunately later on in life, when we need certain types of treatment, for example, like myeloma treatment, then there's a risk of it coming back again. So that's what we call reactivation. So for the two main viruses that I've mentioned, which is the herpes simplex, the cold sore virus, and the chickenpox virus, to try to prevent it from coming back, we do have antiviruses that we can use to try to reduce that risk. And like I said, again, not for every situation and for everybody, but for certain key periods. For example, after stem cell transplant, when people are on it for up to 12 months after the transplant, to try to reduce the risk of this happening, because we do know from very good studies that that is what happens. So of course, we anticipate that risk of happening, and therefore then we put people on these antiviruses for up to 12 months to reduce that risk. Hepatitis B is a type of virus that people can get exposed to depending on where in the world they were born and where they've grown up in. And so if, for example, you've been exposed to hepatitis B before or have had hepatitis B before, we again recommend a preventative course of antivirals, but again, not for everyone. There are certain viruses, for example, again, the cold sore virus and the chickenpox virus associated with certain types of therapy, especially the main ones, which I've touched on before, are things like bortezomib and carfilzomib, tend to be associated with the chickenpox virus coming back, so what we call zoster reactivation. And so when those treatments are being used, that's probably when you see that your clinical team would recommend that you take valacyclovir or acyclovir to try to reduce that risk for happening. So again, a very more targeted approach to things. What about antifungals? Now, we don't tend to think of antifungals that commonly, because by far the most common thing we think about, of course, are bacteria and viruses. But unfortunately, in certain types of situation, fungus can become important to try to prevent. So as highlighted in this slide, the first situation would be after stem cell transplant, because our immune systems are low, and a type of immune cell called neutrophils, which help to fight fungal infections, can be very low, and it takes time for that to recover. And so during that period when it's waiting to recover, I'll go back. When it's waiting to recover, that's when you need to take an antifungal called fluconazole to try to reduce that from happening. Then later on, we touched on before that when you're on steroids in particular, I'll move the slide forward. When you're on steroids, there's this risk of this more unusual and uncommon type of infection called pneumocystis. And therefore then Resprin Fort is the type of antifungal. It's also an antibacterial, but it's used there for that purpose to try to prevent this type of infection called pneumocystis. So that's when you might see that when you're on steroids, you're recommended to then be on Respiratory as well. And of course, the suggested time there is when you finish your steroid or steroid courses, that's when you could potentially then come off Respirin as well. So I think, that's what, by far the most common sort of approaches that we use for the vast majority of myeloma treatments. But what's definitely very exciting, which I'm sure your myeloma clinical team will discuss more with you all, is that there are great new generation treatments for myeloma. And just highlighting here that unfortunately from the infection side of things, we're always a little bit behind in terms of our data about infections with regards to the newer generation types of treatment. So as a result, as you can see here, that the recommendations are not as strong when it comes to the new generation treatments like the bispecifics and like CAR T-cell, where we use some of the data that we know from stem cell transplant and other conditions, or CAR T-cell for other types of cancer, but it's not, the data here is not as strong as I previously discussed with the other types of treatment. So immunoglobulin, I've touched on before. Immunoglobulin is antibodies that are in our bodies that help to fight against and prevent certain types of infection. But we do know that unfortunately, when patients have myeloma, as a combination of the myeloma itself, but sometimes the treatment for myeloma, those antibody levels can be low. It doesn't happen in everyone, but certainly it is possible in some people. So the key thing is that when it's very low, these are some of the levels that we suggest for clinicians to think about, is that when these antibody levels are very low, that's when your clinicians will start doing the workup and to think about whether you need the replacement. So basically replacing it either through once or twice a month, an infusion called IVIG, or giving it subcutaneously, just under the skin, to try to top up these antibody levels. And we do know from good studies that certainly, again, not for everyone, that replacing it can reduce the risk for some serious infections, especially if people have had those serious infections before. So vaccinations, I think, is one of my passion areas, and I certainly think it's very important to think about. And we do, obviously, there's been a great focus on it over the last couple of years with COVID. But our recommendations for vaccines have way preceded COVID for a long time. So these are some of the recommendations that we do give clinicians to have a think about. One of the main ones is against the bacteria, the main bacteria that can cause bad pneumonia and bad meningitis, called pneumococcus. And ideally, at disease diagnosis, that's when people should be vaccinated. And what is recommended there with the little names are two different types of pneumococcal vaccine. One is called Prevnar 13, that covers 13 strains of this bacteria, and followed by pneumococcal 23 or Pneumovax 23, which covers slightly broader strains. And it's given in combination with each other because they both help each other expand the protection against this particular bacteria. So that's one of the key infections that's very important to be vaccinated against. The second one, of course, before COVID was influenza, which can trouble myeloma patients quite a fair bit, especially during winter time. There is a particular formulation called the adjuvant vaccine, or sometimes people call it the old people's vaccine, which I'm not a fan of the name, but of the term, but certainly that's the one that people hear about, where it's given for patients who are 65 and above. Usually for most people, only one dose is recommended, and that's what's recommended under the National Immunization Program. But there's some early data that suggests that perhaps 2 doses could be better. But like I said, this is not reflected, and it's certainly not a formal recommendation in our immunization schedule. But that's an area that could be sort of developed further in the next couple of years. And when it comes to COVID, of course, it's hard to give any talk about infections in anyone nowadays without having to touch on COVID. But certainly, of course, hopefully most people already have had what we call their 3 primary doses. And now for most of our patients, we're going on to recommendations around booster doses as well. Now, while those are the main infections, we often should not forget other types of infections like the meningitis, the main bacteria that can cause meningitis called meningococcus, and Haemophilus, again, a less common bacteria, but certainly a common cause, can lead to meningitis as well. So often those things are also important to be vaccinated against. Now, what I've just highlighted there in the last point is that while we always think that treatment can, negatively impact our responses to vaccination, and that's certainly true with certain types of treatment like daratumumab, but other types of treatment like, for example, lenalidomide or Revlimid can actually perhaps even improve our vaccine responses. So it's not all negative from the treatment point of view. So this is just a summary table looking at the recommendations for patients, especially following stem cell transplant, as those who have gone through a stem cell transplant before know that the intense chemotherapy that we give to prepare people for stem cell transplant, unfortunately, takes away some of the pre-existing immunity that you might have either from prior vaccination or prior infection. And so we do recommend a program of revaccination after stem cell transplant. And I think, an important one to highlight, which is a newer vaccine, which some of you might have heard about, is against the chickenpox virus from coming back, or shingles. And of course, there are 2 types of shingles vaccine. One is a very strong live vaccine, which we do not recommend, called Zostavax. But the safer option is certainly this what we call inactivated or killed vaccine called Shingrix, which unfortunately is not funded yet under PBS, but it is, because it's an inactivated vaccine and does not contain any live virus, is a much safer and effective option. So certainly it is recommended after stem cell transplant, but unfortunately not that widely available as yet, because of the majority of the reason is because of the cost of this vaccine. But we can certainly, talk about it further on during question time. But this is just a summary of the schedule that we do certainly recommend. And here at Peter Mac, we offer this program after stem cell transplant to all our patients. And this is something that has happened more recently as a result of the COVID pandemic, that because we do know that some patients don't respond as well to vaccinations. Certainly, so for those who don't tend to, we have this, or we used to have this, what we call long-acting antibody. So it's different from a vaccine. Vaccines train our own immune system to make a response to the particular bacteria, to that particular virus, whereas these are a bit like those immunoglobulins, but it's just more long-acting and given as a medication, also as an injection. So that's why sometimes there's a confusion for people whether it's truly a vaccine or not, but it isn't. But it's a treatment that lasts for 6 months to try to top up those antibodies in people who may not respond as well to the vaccine, to try to prevent COVID from happening. And certainly we do know that it has been effective when it was first used last year, from the middle of last year to the end of last year, where when it's used, it was associated with lower hospital admission and death. And certainly the breakthrough rate, while still occur, I think no treatment or no prevention is always perfect. There have been breakthrough infections while on this particular therapy, but very fortunately, most episodes of infection have been mild. But unfortunately, as you might have noticed with some of the recommendations from your doctors and treating team, that is unfortunately the current strains of COVID circulating, it's not effective against. So therefore, it's no longer recommended beyond the start of this year. So I always like to think about it as just to summarize and to wrap up, is to think of the different layers of how we can reduce the risk. One, I think for most people, who are eligible for vaccination. That's very important because, so keeping up to date with those more long-term infections, and also the annual vaccinations for things like flu. And now most likely that's where COVID will end up being, more regular, almost either semi-annual or annual vaccinations. Then to think about whether there are these long-acting monoclonal antibodies that could perhaps help people reduce that risk further if they don't respond well to vaccines. While Evusheld is no longer an option, variants do change, and there are new options coming and being developed. So that could change again in the next 12 months or so. And then for a smaller group of patients who have these low antibody levels, then replacing it can also help. And then in the right situation and for the right time, then taking either antibiotic regularly or antiviral regularly could help. Again, not for everyone, but that could be helpful for certain select situations. And then the final thing is to always, I encourage all my patients to be vigilant for signs of infection. So not to ignore it, not to remain at home if they have fevers and shivering and shaking. Those are never good signs to stay at home for. And the key thing is that for a lot of these infections, we have early treatments for. And the key is recognizing them early, getting seen early, and getting treated early, which then helps to reduce the severity for infections as well. So with that, these are just some of where I think the field and infections in myeloma will go. But I think more importantly, perhaps we'll take questions from you guys. And thank you.
And you definitely touched on a lot of the topics that I know I personally encounter as a myeloma nurse in our groups and on the support line as well. So I've got a bunch of questions to ask you if you're happy to answer. The first one is about COVID, as you were talking about, and you can't avoid it in your presentation. So people with myeloma, should they still be isolating and staying home the way that they have done the past couple of years with COVID, or do you have a sort of a recommendation of when they can stop doing that?
Yeah, that's always a very tricky question to answer in a very simple sort of way. Yeah. I think in general, it depends on what phase of treatment that you're in. Obviously, as I touched on right at the start, there are different phases of treatment, and certainly some phases are more intensive than others and require a bit more immune recovery than others. So I don't think there's a sort of simple everyone sort of answer there. But certainly what I still encourage patients to do with COVID, but also other respiratory viruses, is especially indoor type activities always carry a higher risk. So it is a balance of course, living your life and being able to meet friends and family and being social. But I think, just to keep in mind that any indoor type activities, especially with lots of crowds, for any respiratory virus, including COVID, always carries a higher risk. So I would still encourage patients that if they're in that situation, to be careful and to mask up. But again, that's just a very broad recommendation. And I think for specific situations, especially when you're having intensive therapy, or if your disease is back and you're about to start intensive therapy, then I think, to avoid disruption to your care, and obviously as part of your recovery, you should always take advice from your clinical team about what sort of extra precautions that you might need to take.
Very well answered. While we stay on the topic of COVID, another question is regarding the injections Evusheld. So a lot of people have received this in the community, and there have been questions about whether another type of therapy like this will be available on the horizon or in the short term. Can you talk a bit about that?
Yeah, without sort of, without mentioning any specific products and things, I think one thing good about Evusheld is that it was effective when we were using it. But as we all know, because it's such a bespoke design, as it was targeted to certain strains of COVID, and of course, as strains change, unfortunately, it's not been effective. And that's sort of been the story with these antibody therapies for COVID, from the sort of the start of the pandemic. So, but to answer your question specifically, certainly people have found this approach to be helpful, this long-acting preventative approach, so not treatment, but prevention, have been found to be effective. So the companies, different companies are making new products, but they're all sort of in the evaluation phase in clinical trials. So there might be clinical trials, depending on where you are, of course, in Australia, there may be clinical trials looking at this question, or the next generation of something similar to Evusheld as a prevention. But I think, it'll be negligent of me to mention things because I think, they're being studied. And so we don't know if they'll be effective as yet. But certainly the approach of using these long-acting antibodies as prevention, certainly I think is here to stay. It's about finding the right, more effective product.
Thank you. You also, as part of your talk, you were talking about the Shingrix vaccination, which you mentioned is not PBS listed, but there are people who are receiving it. And for the people that have received the full course of the Shingrix vaccination, do they still need to keep taking their antivirals like Valtrex or valacyclovir?
Yeah, great question. The quick answer to that is no, but also depending on the situation. So I'll explain my answer there in two parts. So if for example, if it's after a stem cell transplant and you've completed the 2 doses of Shingrix, then in that situation, you don't have to keep taking valacyclovir. But why I've qualified my answer is just because in different scenarios where people have had Shingrix, but then have had to go on to, let's say, another proteasome inhibitor, so more calcifimab or more bortezomib, then in that situation, we're not sure if Shingrix alone is enough to prevent shingles. So then in most, I think, clinical teams, they would be more cautious and still recommend people take Shingrix in that situation. So, but if it's after transplant, and you've completed your course, and let's say you're on Revlimid as a maintenance, then you should be able to stop your valacyclovir.
Thank you. Is there a specific time frame that you need to wait between having different kinds of vaccines? So if you use Shingrix, for example, do you need to wait before you have another COVID booster, or is there any other sort of time frames that you could talk to?
Yeah, so look, in general, the vaccines themselves can be co-administered. So there are very few, of course, again, always check with your providers for specific vaccines. But in general, most of the vaccines can be co-administered without, needing a break between themselves. But as you can see from the previous slide I've shown, is that vaccine schedules are very complicated, and they are all sort of scheduled in a certain way. So it's more important to maintain that schedule rather than sort of focus on, whether they can be given together. But if the schedules line up, like after stem cell transplant, we can certainly give, for example, we do up to 4 vaccines in the same sitting. So that shouldn't be a problem. It's just making sure that whatever vaccine you're having fits its schedule.
Thank you. You've done really well at answering some kind of curly questions that are often requiring a specific answer on a patient-to-patient basis, but you've done really well. So thank you very much.
No worries. I mean, I've tried to give as broad an advice, at least, of course, when it comes to your specific situation, it's always good to get a specific answer from your clinicians. And if they are not as certain, of course, they can seek additional advice from, I'm sure there's lots of equivalents of me across different teams. So I think it's always important to get specific advice if you're not sure.
Definitely. Thank you so much for giving your time this morning and for sharing so much with us.